Of the members of the Division of Pediatric Rheumatology, and I'm excited this morning to introduce you to our Division Director, Dr. Rich Vehe. Dr. Vehe has been at the University of Minnesota now for 25 years and has been the Division Director of Pediatric Rheumatology since its inception 21 years ago or so. And he is taking on the big task of trying to get to a practical approach to an ever-expanding area of medicine, which are autoinflammatory diseases. So, with further ado.
Okay, does that sound okay? So I have not given this talk before, so this should be an interesting adventure. My disclosure is that I have no financial relationships relevant to this, but I will make mention of some meds that perhaps will be listed as off-label. I'll try to be very clear about this. The problem is we're dealing with rare diseases for which there are rarely approved meds. So the goals for today are for you to be able to describe at the end of this when to consider autoinflammatory disorders, how to distinguish them from autoimmune and immunodeficiency disorders, and some practical improvements that are occurring in diagnosis and management. I'm going to try to give you some tools along those lines. And we will be sticking to the left trail here, the easy trail. We will not cross to the dark side, the difficult trail. So I'm not going to provide an encyclopedic review of autoinflammatory disorders or their pathophysiology. It has become such an enormously complex topic over the last 19 years that there's no way you can create a slide that highlights what's going on. Each disease is a complex pathway now, and instead of 3 or 4 diseases, we have dozens of examples. So what are autoinflammatory disorders? There may be things that pop into mind just from the word itself, autoinflammatory, and I think this is the way most pediatric rheumatologists feel about it. Actually not a quote from one of the leaders of our field, but rather by Winston Churchill talking about Russia, but it seems apropos to what we're dealing with because these patients show up with the most confusing pictures at times, and right when we start to think we're getting a handle on them, something new pops up that changes our impressions. So if you were to go look for this quickly and do a Google search, the first thing you'd come across is Wikipedia, and you'd put in autoinflammatory disorder, but you'd get periodic fever syndrome. And this is a good example of partially true information and the danger of internet searches, but I will give you some references later that you could find easily if you've lost all the references I give you. Maybe some of these names will stick with you as reliable sites. So the first thing I notice here is it says that this is in the section called endocrinology. This field has really come out of the world of rheumatology in some ways by accident. It just had investigators who were involved in mapping the genes early on. But it turns out now that we actually are seeing its relevance to endocrinologic disorders, including things like gout, if you want to call that an endocrine disorder, but also diabetes. So the rest of this is also mostly true, but partly misleading. Periodic fever syndromes, which is a term many pediatricians are familiar with, is not entirely synonymous with autoinflammatory disorders. That autoinflammatory disorders is actually a much broader category of disorders. And they are distinct, as it says here, from the autoimmune disorders rheumatologists or other specialists usually deal with, in which we think about the adaptive immune system, the T cells and B cells, having specific immune events. This is different. This is the innate immune system spontaneously doing things that lead to harm. Most of these are genetic, and they mostly do start in childhood, but that is changing dramatically. We're now recognizing adults with their initial presentation due to mosaicism. And while the early conditions that were identified, such as familial Mediterranean fever, are associated with a particular complex of proteins known as the inflammasome, we're now having a variety of pathways of inflammation that are leading to pathology. So it is still true, though, that cytokines play a big role in this. You get a hypercytokine state, and we do have some inhibitors now that specifically target some of the major categories. So I'm going to want to start with a case example from our clinic. It really illustrates nicely how these patients can present and how they should be worked up. So 4.5-year-old with a history since 9 months of age of 3 to 5 days of fever every 3 to 4 weeks, and it was real fever. The episodes were marked by a change from what was described as a pretty chill kid to a fussy kid. So the parents would just look at him and go, it's going to happen again. They see it evolving in front of their eyes. Next, like a switch was flipped, he would start with fevers. And the first day they'd be to 101, but then they would get worse on subsequent days. He would get a sore throat, and he had documented erythema of his throat, negative throat cultures for strep and rapid streps, and he would have cervical adenopathy. And sometimes he would have a headache, sometimes he would have abdominal pain with or without constipation or diarrhea, and he would get leg pain rather diffusely. So myalgias, arthralgias. Early in the course, they of course looked for infections, which is important. He ended up having chronic effusions in his ears, so he got a set of PE tubes, and that helped resolve those effusions as well as recurrent infections, but he kept having these fevers. And then he was completely normal between episodes. They had a normal, happy, healthy, normally developing child. So all the residents better know this one, or before they graduate, better know this one. Does anyone feel like they want to toss out a name? So if you just put in fever and pharyngitis, it adds the third word, lymphadenopathy, for you, and it brings up PFAPA. And the reason I brought this Google search in is because this first reference that pops up, at least for me, is the one I want you to know about for the future. So this is the American College of Rheumatology site, and they have patient education materials, but I think it's really good information for the physicians as well. It starts off with these basics about how common this is in children in particular, and what it presents as, how it's managed. If you go to the second page, you get even additional information in great detail, I think is very accurate. The person who wrote this, Dr. Phil Hashkis, listed it down here at the bottom, is really an expert in this area. And then there are expandable links that give you even more detail. But importantly, on the first page, there's also at this other arrow I inserted, this PDF, and I would really encourage you share this with your families, because if you don't give them reliable information, they're going to go and try to find information, and it may not be as accurate. So this is a great resource. So going back to this case example, Dr. Google seemingly was never consulted on this patient early on, and this child, it turned out, had gone through a naturopath evaluation and management, and then had an infectious disease evaluation, which led to referral to rheumatology. And our rheumatologist quickly, very thorough history and physical, but identified that this was likely PFAPA, but importantly, listed the mimics we always have to consider with one of these children who presents with an autoinflammatory disorder or a periodic fever syndrome. We have to consider infections and malignancies because they would greatly impact the therapeutic approach. We have to think about a variety of genetic syndromes, and we have to consider immunodeficiency. PFAPA, as you will see, or if you read those websites I showed earlier, they make a statement that it's not genetic, but it's only not genetic if you have correctly identified it and not picked up one of the mimics. So it turns out that there are patients with genetic syndromes who present looking just like PFAPA, but if you identify the gene, you reclassify them. So after appropriate evaluation, the child then receives standard treatment, which is a single dose of prednisolone when the parent notices a change in behavior. You don't wait for the fever, you just treat right away. It completely ablated each episode. So no longer 3 to 5 days of trouble. Literally in hours, it's all over. And then this doesn't always happen, but this child progressed to having a tonsillectomy done, and as is often the case, that resolved the problem completely for this child. So that's an easy one. the rest of them are a little more complicated. And one of the problems we've had is how to name them and classify them. And when I gave grand rounds earlier this year, I mentioned an organization called Printo. And this is an organization that we partner with. North America has its own organization. We do a lot of studies in combination with Printo, but I'm going to mention Printo so many times in this talk, I thought I'd highlight again that they're all over the world. It's based out of Genoa, Italy, but it brings centers together around the world to do cooperative research. And just in the last few months, this paper came out, Consensus Proposal for Taxonomy and Definition of Autoinflammatory Disorders. I have a little bit of problem with that acronym, so I'm going to try not to use that acronym too much. It just gets confusing. So they started with this sentence, which is autoinflammatory diseases are clinical disorders caused by defects and dysregulation of the innate immune system. So again, highlighting the difference between this and autoimmune disorders, it's all about the innate immune system. And we define them clinically. Genetics testing plays a role, but genes themselves are not in isolation the cause. They're characterized by recurrent or continuous inflammation and they make the point that you have increased acute phase reactants. We get referrals for patients who've never had acute phase reactants checked, and yet someone wants to know whether or not this child has an autoinflammatory disorder. And they're characterized by the lack of a primary pathogenic role of the adaptive immune system, which is not to say that there's no role for the adaptive immune system. There actually is increasing information that there is a role. And usually at this point, we launch into diagrams of pathways of the receptors that are involved in setting this off. But I went with the simplest examples I could find to review for people the difference between the innate and adaptive immune systems and how they play in. So whether you're a vertebrate or not, there are physical barriers that keep you safe in this world. If you're a human being, you have this next line of defense, and both the physical barriers and these cells of the innate immune system and their molecules provide us protection against anything we come into exposure, we get exposed to in the world. And this is something that is a learned system over here, the adaptive immune system. So one of the points they made is that the word unprovoked, so although it's called autoinflammatory, it needs to be taken as self-inflammatory as opposed to, and that it's an overreaction rather than it's one occurring in isolation, because actually these are often provoked by events. And again, similar diagram as to what I showed before, but the point is whether it's microbes or damage, these processes can be triggered. So microbes, pathogens have molecules on their surfaces that fall into certain patterns. Damaged tissues have molecules on their surfaces that fall into certain patterns. And we have pattern recognition receptors on cells of our immune system that can recognize that there's either damage or a pathogen trying to invade. And that then precipitates a series of internal events in cells leading to an inflammatory process. And again, going with the simplest diagram I could find, this just points out that you can break it down roughly into pathogen triggered events or other physical events that lead to damage. And for many of the disorders I'll discuss today, the key complex molecule formed is an inflammasome. This leads to cytokine production, including the eventual induction of interferon gamma in many of these disorders, and you get inflammation. So that's the only diagram I think I'm showing you today that's even resembles pathophysiology, and it really doesn't. So again, we have activators, we have receptors, the result is inflammation. But the question then is, well, how should I keep these in mind, and how will I recognize these? Are these just monogenic disorders? Yes, they often are, but they're not always. So it's complex. So you can have family trees that show exactly how the gene has been passed along, and yet the affected individuals will not correspond. And you'll even have individuals who have the disease who do not have the major genetic determinant of the disease. Are they only childhood onset because they are genetic? Well, they're not anymore. We're now recognizing that there are individuals who are mosaics and that they have late onset or that it's a modifying factor in part of a more complex disease. Is it really completely different from autoimmunity? Well, it's mostly different, but the lines are getting blurred because we now have autoinflammatory disorders that, if they go long enough without treatment, show autoimmune features. And we have autoimmune diseases that clearly have an autoinflammatory component that needs to be addressed for optimal management. And are they really the opposite of immune deficiency? I mean, this is overactivation. How does that relate to immune deficiency? Well, it turns out that that line is getting blurred as well because we're seeing some individuals with minor and major immune deficiencies. And people have tried to come up with diagrams to explain this. And I don't expect you to understand this because I can't understand this attempt. I'll show you 3 examples that I think really very hard to explain how these might relate. So down here, we have disorders of T and B cell function that clearly fit into the category of immune deficiency. Then we have more clearly monogenic disorders that have autoimmunity as well as immune deficiency. Then we get into our classical rheumatic diseases, but as you can see, there are a number of other specialties in here, especially dermatology has a number of disorders. We've always viewed in our field that ankylosing spondylitis and reactive arthritis and psoriatic arthritis are somewhat different. And we've never been clear where to put sarcoid, so it ends up in the next 3 categories, actually. And in fact, this one, Blau syndrome, is something we have patients with this here. It's an early onset sarcoidosis that is monogenic. And then finally, we have these horribly complex disorders, and I think a number of people here in the residency, as well as on the faculty, took care of a child this past year with DADA2 deficiency, in which we had infections, autoimmunity, and immune deficiency going on. This is another attempt, and the key point about this slide is just to say there are things that are mostly related to T and B cells. There are things that are mostly related to the innate immune system, which is the myeloid cells. There's this whole group of things in between, and then there's the role of environmental triggers for these disorders. And again, we have things that might fit in the metabolic world or the GI world or the dermatologic world in this. And yet another attempt, because there is no single way to do this, just separates them into immune dysregulation, immune deficiency, autoimmunity, and autoinflammation, and tries to show all the different ways these might overlap. So it is enormously complex, and each of these has its own biology. There are a few examples where you'll have 2 or 3 things that are nearly identical, but they're not, and I'll show that in a minute. So when should you be suspicious? You should suspect a periodic fever syndrome when there are recurrent inflammatory episodes, generally unprovoked, often with a repetitive pattern of symptoms and signs, and of generally predictable duration, and sometimes at predictable intervals. So when we get one of these in, I just ask the family, can you tell me what this is going to look like? Can you predict what the next one will be and when it's going to be? And they often can do that. The onset is often early in life, but not always exclusive. When do we think about the other autoinflammatory disorders? Well, we do that especially when there's an unusual presentation of something we think of as an autoimmune disorder. So if you have someone who has inflammatory bowel disease, but it presents in the first year of life, or lupus that presents in the first few years of life, that's not typical, and especially if they have other serious manifestations. So it isn't just that it presented that early, but it presented with severity that was unexpected, and especially we see a lot of vascular injury to skin and internal organs, and we see bone lesions in a number of these disorders. And then if you also see unusual infectious complications for a patient that you thought had an autoimmune disorder. So our medicines affect immune function. We make kids more susceptible to infection when we treat autoimmune disorders. But these children, sometimes it becomes clear that this isn't right. Kids usually tolerate these meds better than this. And then we have to make sure we've considered immune deficiency. The approach is like almost everything else, and I had a slide in here from my usual talk, but I took it out to save time. It's a history and a physical looking for evidence of infection, malignancy, immune deficiency, and autoimmunity. And then we want laboratory studies. And it's a relatively short list. We want to check inflammatory markers when they're ill, but also when they're well. We need evaluation for infection and malignancy. And for the most basic screening you can do, and you can always do more, we would do at least these studies. And then you would do other labs as appropriate for other considerations. So if the patient's presenting with a lot of GI symptoms, you might be working them up for IBD. If the CBC showed cytopenias, you might be looking for a lupus-like process. And then there may be imaging needed. As I said before, you can have bone involvement or other internal organ involvement. So the role of imaging can be small or large, and the specific imaging very much depends on the situation. With regard to bones, it can be a bone scan. So then you just go to Lab Guide and you put in periodic fever on the left here and you order this panel, right? So please don't do this. And this is like, for us, the ANA test. We just don't want it ordered until the time is right. Besides which, it's not going to get run because a nurse or hasn't been contacted to do the prior authorization, or a genetic counselor hasn't been involved. Instead, you're going to go through a clinical process. And I just want to point out that you really can figure these out clinically. I'll go back to a really old example, not an optimal example, but a good example. So I had a patient present as a 2-year-old, and the complaint was, well, he's really struggling walking, and his knees are warm. And when I examined them, yeah, they were warm, and I couldn't fully extend them because they hurt. And his past medical history was only notable for this urticarial rash that he'd had on and off since 6 months of age. And I have to tell you, I followed this kid for over a decade, closer to 2 decades, and I never saw the rash. So it really was evanescent. So the thought was, well, he must have a form of juvenile arthritis. He started before 16. It's chronic. He had this 2 out of 3, loss of range of motion due to pain, and he actually had the warmth as well. And I couldn't think of anything else. I joked with my patients that idiopathic does not mean I'm a pathetic idiot, but in fact, I couldn't figure out what he had. But it was a little bit bothersome that I couldn't get him straightened out. And so, I kept thinking about the anatomy. And for arthritis, the reason that this definition exists, swelling or effusion, or these findings, is because we're looking to see if the problem is the synovium. I lost my pointer there. Is it the lining of the joint where the problem is, or is it outside of there? And that's where the surprise comes in this story. So we always do imaging. It gives us information about location, process, and priority. And his initial knee x-rays were fine. And in fact, his follow-up x-rays 6 months later, when I was struggling with him, were still fine. But I still thought, well, playing the odds, this is no longer acute. It doesn't seem to be an infectious illness. We've worked him up for that. And he still has tons of inflammation on his labs, and I'm struggling to get him to turn around. So I still thought JIA was the most likely diagnosis. Well, this is an example of something no longer idiopathic. So markedly elevated inflammatory markers, anemia, chronic disease. Worked him up for IBD because his lab seemed so out of proportion to what I was seeing. And we started him on therapy, and his response was lousy. But then follow-up films another year later, and then a few years later after that, which I'll show you, point out how off I was on the diagnosis. Your knee should not have a chunk missing up here. These are his growth plates, and these are actually fine. But here's how it progressed by 5.5. These giant, enormous cartilaginous knobs had grown off his epiphyses. And this is absolutely characteristic of one particular disorder, which at the time we had no effective treatment for. So the fact that I had not figured out his diagnosis right away, it took me close to 15 months, didn't matter. He had something called NOMID, neonatal onset multisystem inflammatory disease. It's part of a family of disorders known as the cryopyrin-associated periodic syndromes. And there's 3 of these in particular I'll be mentioning, and they share certain features at the top their rash. They feel lousy. They have headaches. They have joint pains. They can have fevers, and they can have eye inflammation. His particular form is really one of the intense. And the NOMID Alliance, which is came into existence, I think over 15 years ago now, really has made the point very clearly. This is an incredibly intense problem. And we didn't know it. He was developing normally, but he actually had a chronic aseptic meningitis. He had some ocular involvement that had been missed initially on slit lamp exam. And he certainly had these joint problems. We eventually, several years into it, he was having hearing loss develop. He actually became one of the kids enrolled in a major study that proved that there was effective therapy for this. But internationally, everyone had thrown up their hands on this disorder. There was nothing that would turn this around. You could give him any chemotherapeutic agent you wanted, and it did not make a difference for this disease. And so the NOMID Alliance is a good source for information. It's one of the two reliable sources I want to point out. It's part of major organizations that deal with rare diseases, and they have a variety of bits of information for you. And one of the things that many of us have relied on for years, and this is part of a table, I cut it off so you can actually read some of it, but it breaks it into what is the disease and then what are the systemic features, and you can use the rest of the table as a cheat sheet to quickly sort through these patients. And you'll see that this is from 10 years ago. It was kind of confusing what they thought the gene was in these different disorders, but it points out the four big things that we've dealt with over the years. Familial Mediterranean fever is the most common autoinflammatory disease we deal with that is genetic. TRAPS is the one we see the most around here. Igg syndrome is the one I probably see the least of. I'm not sure I've actually seen a full-blown case of it. It's also known as mevalonate kinase deficiency, and it especially can mimic PFAPA. And then there are the cryopyrin disorders, which are all mutations of NLRP3, and they cause either NOMID, Muckle-Wells syndrome, which primarily shows up in derm clinic, or familial cold urticaria. So this is the cheat sheet we would go to, and it very nicely would say, okay, I did a history and physical. What abdominal symptoms are helpful to sort this out? What do I know about their skin? What do I know about their eyes? And it was great. So this is a great resource, but this is what it looks like now. And good luck with this. I will say, don't print this out. Get it on a screen, download it as a PDF, and magnify it, because it is absolutely wonderful. The pictures are great. The information in here has been improved over time. And so you already saw the one about the CAP syndromes. They've really not only enhanced it with new information, but they've cleaned it up as new information has come along. But practically speaking, are you really going to go to that table if you have a patient you're suspicious of? I don't think so. So Bryce Binstad pointed out in our journal club a few years ago a paper that came out from Printo, that organization I mentioned at the beginning. And it's part of something they're doing called the Eurofever Project. And this is a great web page that Printo has. And you can see line by line all the things it goes through. I'm going to highlight this last line, which is their classification criteria, their diagnostic tree, and their genotype-phenotype correlation work that they're doing. Again, they have a list of many of the disorders. The list just keeps expanding, and they're not touching on all of them, but they're trying to make progress in this area. And this is a great little thing they came up with called the Eurofever Clinical Diagnostic Classification Criteria for FMF, mevalonate kinase, which is hyper-IgD syndrome, TRAPS, and then the CAPS category. And you get points if you have a feature, and you get points if you don't have a feature. So if you don't have aphthous stomatitis, you get 9 points. So it's a little confusing, but then there are cutoff scores. And so that's really nice to have, but even better, they actually perform well. So these are receiver operating characteristic curves, and they show how tightly correlated the test group as well as the validation groups are. And the sensitivity and specificities are especially good for the top two disorders, but not quite as well Not quite as good for the lower disorders, but still pretty good sensitivity and specificity if you look at the numbers in the tables there. Well, what they've done now is they've made it an online resource. So you just go to their web page and you click on it. And if you've taken an appropriate history and physical, and you could print this out before you go into the room, and you put it in, it'll calculate what their score is and tell you what the likelihood is that they have one of these disorders. And that's a nice thing to have. Now, that's all based, again, as I said, on they had test examples and then they validated it on a group. But as we know, patients don't read textbooks very well. So what they've also done is they've started collecting genotype-phenotype associations through a web-based registry, which will expand our knowledge of the variants and how familial background or genetic background can change the presentation of these disorders. And that's a pretty exciting thing. So if you've gotten to the point that you've figured a lot of it out, you may yet need to do confirmatory studies. And we commonly will do this. We used to order them one at a time, but because the patients often do not cleanly fall into categories. As I mentioned, you can have genetic syndromes that resemble PFAPA. That includes TRAPS, we see that with, and we've seen it also with some of the other genetic syndromes. And you certainly see it with hyper-IgD syndrome. We used to order specific tests, but increasingly people do panels, and now this is readily available here. It used to be difficult to find. The NOMID Alliance still lists reliable labs to choose, but the great thing is we have it here at the university. We usually ask our genetic counselors to help with this. At least we try to, because there's going to be information to discuss and explain, and they're more adept at navigating the pathways of getting these things approved. So after identification, what next? You stop there. As I said, many of these, the biology of each of them is unusual and different. And what happened originally with NOMID, it turned out there was a product sitting on a shelf not being used. And it was a breakthrough when people realized it would work. Well, really simple. You just want to make them well. So you go this way and you seek out effective therapies. But there is no one-size-fits-all therapy. For the disorders I've mentioned primarily today, interleukin-1 inhibition has been the primary breakthrough. We've also used TNF inhibitors for TRAPS, but even that disorder, which is an abnormality of TNF metabolism or signaling, it turns out responds really well to interleukin-1 inhibitors. But we do have a problem in that they're not all equally approved. So anakinra is a naturally occurring IL-1 receptor antagonist. We have interleukin-1, it lands on a receptor, and it signals a cell to do something. We have a naturally occurring plug for that receptor that keeps the IL-1 from interacting. Think of it like an outlet cover in your home. It keeps things from happening. And this has been cloned and it can be administered. It was originally brought on the market for rheumatoid arthritis, but its primary use has been outside of rheumatoid arthritis. And it is approved for children and adults with NOMID, but not necessarily the other forms of CAPS. Still, it gets used because it works quickly and it gets out of your system quickly. So if there were going to be a problem, which there probably won't be, it's quickly out of your system. It's one of the interesting ones also that, as I said, there's often a question of fever being due to infection and the concern that they could have immune deficiency with a really weird infection that you didn't quite figure out yet. This thing can actually be given to incredibly sick individuals, even individuals in sepsis. Ilaris is a newer product. It's a recombinant anti-IL-1 beta monoclonal antibody, and it's approved specifically for the CAPS disorders above the age of 4, TRAPS, mevalonate kinase deficiency, and familial Mediterranean fever. Now, most people with FMF are on colchicine for life. Colchicine historically was what we gave every fever patient as almost a diagnostic test to figure out if they had FMF. They got better, they probably had FMF. But colchicine is still used, but there's a group of patients for whom colchicine is not sufficient. And then the third one is rilonacept, which is the IL-1 receptor with a human IgG tail attached to it to keep it in the circulation longer. And it's approved only for CAPS age 12 and up. So it's not approved for these other disorders. So this is the off-label part of my talk. Desperate times call for desperate measures, and we sometimes end up using any of these because we keep trying to get full control for these patients. And it really is a remarkable time. The boy I was mentioning earlier with the bad knees, he was in the pivotal trial that showed that anakinra works. It really was transformative to his life, and he grew up to be a happy adult. So, as I said, I wanted to just give you some tools to work with today. I hope some of that will stick with you and you'll be able to use it in the future. For those who really like to get into the science of it, there's just a ton of new information out. And I even have references for something that's not yet technically released. It's for next year, so this was an early release. It's an enormously complex topic. I don't think there's a specialty that won't be touched by it because these patients have everything from their hair falling out to inflammatory brain disease to serosal disease affecting their heart, their lungs, their belly, musculoskeletal problems, cardiac muscle involvement, pulmonary involvement. It's becoming relevant. This issue of innate inflammation and how it should be modulated is becoming part of consideration for many disorders that we've been taking care of for years. So it's a fascinating time. One of the things I will say, though, is it's getting too complex for any specialty to own. So we do get consulted in the hospital, and you should feel free to consult us, but realize at times that we might not be enthusiastic because we can't own this field. And I'm glad to see Paul Orchard here because Paul has actually addressed this issue of how, as an institution, we should be thinking about helping individuals with rare diseases as well as helping the world better understand these rare diseases and diagnose and manage them. So with that, I will stop and take any questions. Paul.
So I have a couple questions, but the first one was related to this survey. Oh, thanks. The first one was related to this survey registry-based mechanism that you talked about a bit earlier. So being able to correlate phenotypes and genotypes, for instance. So are you guys involved in that? And I mean, what's the organizational structure for that and who funds it and whatnot? Because those things can be exceptionally important.
Yeah, so our major work here is within the North American consortium called CARA. And CARA partners with Printo on many things. And we have a registry for diseases, but because of financial and logistical issues, it's rolled out with the most common diseases first. But within CARA, we have a group of people who are focused on these disorders, and the point of the registry is to make it part of routine care. We're still doing paper-based entry within CARA, but we're working towards, there'll be more discussion of this in January in Atlanta about moving towards automatic data transfer from electronic medical records.
And who funds that? Is that NIH funded or is it advocacy-based funding or?
So CARA originally was funded in large part from the Arthritis Foundation as well as some federal funding. But what they did was they retooled the registry so that it's also supported by industry. And the reason is that all these new biologic products that come to market have to have ongoing surveillance studies done. So we're following the patients. They're on whatever therapy they're on, it's in the registry, and then the industry can have access to that data. So working with the FDA, working with industry representatives, they retooled our database a few years ago to make it a very mineable database that will fulfill the requirements for long-term monitoring.
Thanks. The second question related to off-label use of some of the IL-1 and antagonists. So how how do you guys get that to work? I mean, has it been a huge problem, or do you have groups that help you do that, or do the companies, go to bat for you, or how does that work?
The people in front of you are smiling, people from our group.
I noticed that, yeah.
So the typical example is that the patient is hospitalized. They get started on anakinra. They look better overnight. I mean, it works immediately. And we say, guys, as part of the discharge planning, you've got to have this stuff available. They almost always go home and it falls through. But because it's such a commonly recognized problem, the company, Sobi, which is Swedish, has a program that if the patient has a known clear reason to be on it, they will just ship supply while you're working on the prior authorization. They'll give you some free supply. And then it's a very frantic effort to make sure the authorization goes through. So as much as the hospitalist teams, the residents and the staff work to get assurance that this is approved, I would say the majority of the time it fails, and that a few days later we're in a crisis. And that's where our office ends up having to deal with this a lot. Longer term, I think if you have a genetically defined syndrome, we would like to work more closely with our genetic counselors and have them routinely involved in not only those issues, but the long term, as the information evolves, these individuals the families need to be educated as to what we know about these disorders.
Thank you, Rich. That was fantastic. I particularly appreciate the fact that I understood your slides. As a developmental behavioral pediatrician, I always look forward to these talks with a little bit of trepidation about whether or not I'm going to understand it. I was wondering, looking at those complex diagnostic classifications and sort of diagnostic algorithms and the high rates of sensitivity and specificity, I was wondering what you knew about artificial intelligence, self-learning systems, decision support. This, to me, as a developmental behavioral pediatrician, feels like the kind of problem where I would want R2-D2 following me around and sort of running these complex diagnostic algorithms for me and coming up with some diagnostic possibilities as we work up these patients together.
Well, specifically with regard to these diseases, I'm not aware of anything quite at that level. I mean, you have to go to the web page and enter the numbers. I think it is an ideal candidate for that. And then, of course, with any of these tools, there's always the caveat that you have to use your judgment. There are all sorts of assumptions when you're filling this out, and you have to make sure you haven't overlooked certain things like, the patient also has a diagnosis of tuberculosis. How does that play in? Is that a sign of immune deficiency, or is that the actual cause of their problem? With EPIC, I spend time doing informatics work, and with EPIC, clinical decision support is a growing area, but it's still very simplistic. So it mainly is helping individuals to avoid harmful pharmaceutical combinations. And sometimes I would say in primary care, it's one of its strong points. It's informing people that based on this patient's age and gender and health history on their problem list, we should be considering this. So I think in time, this could be something that EPIC and Cerner and other organizations would build into their EMR. But we're talking about rare disorders, and I think rare disorders, it comes down to the zealots. The families drive these things. Families drive this. They drive investigators to be interested. Investigators find it fascinating. But we're talking about a relatively small group of people worldwide, and you got to find one who really wants to go down that path of AI.
Rich?
Yes.
Over here.
Brad.
So 2 questions. One was a follow-up on Paul's about the registry with genotype, phenotype correlations and web-based approach. How does that work with the safety, privacy issues, especially in Europe, about that data? Is that being entered by the patient, the local center, a little bit of both?
So I haven't I haven't actually enrolled a patient in it, so I don't know if you make up an identifier or not. I'm sure you don't put identifying data in. There is as or more stringent in Europe on these issues, and this is an EU-supported project, is my understanding. So I don't know if you have to create a local identifier for them or not.
But is it, there's not a patient portion of entry. This is all the physician centers.
Correct. That's my understanding.
Right.
Yeah.
My second question is actually maybe for you and Paul, and that is, how does transplant affect this system in terms of autoinflammation?
Well, some of these disorders, clearly their best option is transplant, especially some of the patients with immune deficiency. The patient we had here with DA2, that was the goal, was to get him to transplant. He was a late presentation and had enormous infectious complications and didn't make it to transplant. But it is currently the definitive therapy for some of these more severe monogenic disorders.
And I guess the second step to that...
We have the experts sitting here.
The second step to that would be, does transplant lead to some of these autoinflammatory conditions? And I can give it to Paul.
We certainly have seen autoimmune complications. We've seen autoantibody production. We've seen, and our dermatologist may argue with, is psoriasis truly autoimmune? Is it autoinflammatory? Is it something unto itself? But, I know I've seen some post-transplant patients who develop terrible psoriasis. I don't know if that's common or I just had bad luck, but maybe Paul can, or Troy can address this.
Well, nobody that maybe Troy can chime into, but nobody that I know of is really kind of focused on these sorts of disorders in terms of transplantation. Occasionally the severe patients come to us and we consider transplant. There's a lot of interest, for instance, in the MS field, especially in Europe, to do auto transplants. So essentially, you harvest stem cells and you eliminate whatever you can from the immune system, and essentially reinfuse the stem cells and restart the immune system. And so there's a lot of interest in that sort of area, but obviously these things don't come up very often. And interestingly, we do see a lot of autoimmune issues or alloimmune issues after transplant, and trying to figure out exactly what's driving what is difficult. But there's a patient going to be putting on plasma exchange here in the next few days who's got severe antibodies that are, eliminating platelets and red cells and maybe neutrophils as well. So, we see a lot of problems in the post-transplant dysregulation sort of mode, especially the very little kids for whatever reason.
Yeah. But it is the myeloid cell line that is driving much of this, we believe. So we would think that transplant could help these kids, but I'm not actually aware of transplants being done. I don't know, Patty, if you or Colleen are familiar with transplants for many of these disorders. Any other questions? Yeah, there's one back.
That's now considered a primary immune deficiency, and if you can make that diagnosis, that would be the treatment of choice. And then certainly the data too, there's a number of folks who've put together an international report on all the patients that have been treated, and that's really the approach for that diagnosis as well. So some of these other ones, if antibody-directed therapies wouldn't be effective, there are only case reports really of the transplants for the individual diseases.
And the reason thank you for that information. The reason to consider transplant, again, those early onset IBD patients, they're incredibly sick, and and conventional therapies don't work effectively, or you can't use them in a way that's tolerable. But many of these disorders, because of the chronic inflammation, I glossed over this, but the chronic inflammation leads to the production and deposition of amyloid protein. And lifelong disability or death from amyloidosis is a problem. You get it in the gut, you get it in the kidneys, it leads to renal failure, It leads to chronic malabsorption. It's a big deal. So people diagnosed with FMF are on therapy for life. There is no option right now besides therapy for life. Any others? Just a question in the back, Sean?
They're suspecting some kind of intermittent autoinflammatory disorder. How urgently should they complete a workup? Is there concerns about long-term harm if this goes undiagnosed for a period of time?
So some of the websites will tell you about PFAPA, that it's benign. I don't think if you're the parent or the child, you'd say that. They are miserable and they are sick. And the case I presented, it wasn't my patient, but I believe that child actually had a febrile seizure as well. So on the other hand, there is no lifelong risk of amyloidosis with something like PFAPA, and it actually is reported to burn out. I say reported to because medicine is famous for saying that things will go away, but really the patient just goes away because they're sick of hearing you say, don't worry, this will go away. And then for these other syndromes, so FMF, you're not going to develop amyloidosis as a pediatric patient. You can develop other significant problems and have many trips to the ER. We've had patients develop significant vasculitis with FMF. It'll look just like HSP vasculitis. So you want to be thoughtful. And again, it's not going to, you don't want to jump to the conclusion that every time there's 3 fevers in one winter that it's an autoinflammatory disorder. And Patty's nodding her head because Patty's had the brunt of these, it seems like, over the years. And she goes in and does a history and physical, and it turns out that many, if not most, of the kids referred for this have turned out to have explanations for why they had fevers. So you don't have a runny nose with any of these. That's the bottom line. And so you do want to move quickly enough that they don't progress to the point that some of the kids we've seen in the hospital that have immune deficiency associated with it, and they're getting severe infections and unusual infections. But it's, this winter, I hope we don't have a rush of everything's autoinflammatory, because common things are common, and it's infection season.
So that's a nice segue to my question, which involves fever. So here in dermatology, we've had a few cases recently that we're working up for periodic fever syndromes or autoinflammatory. But fever is not a prominent symptom, at least in these particular cases. Can you comment on that? These are a little bit older kids. Do you think that maybe they're less likely to present with the fevers? Is it that they're not checking for it? What do you think?
Well, I think we all know that we have families that overcall and undercall things. I don't know if there's as clear of an age difference. I'm sorry, I don't have that answer. I will say that the problem with the term periodic fever syndrome is not everyone has fever. So the boy with no MIT, fever is not a part of his disorder. If it was fever, we never documented it. His parents never complained of it. He just looked bad. So there are periodic fever syndromes that should include fever, but they don't necessarily have that prominently. Some of these other ones, though, we really hang our hat on the severity and the duration of the fever. And there's actually another, we've got a minute. That's about all we have. This is another case. This is the one Bryce saw. And it's a reminder that all diagnoses are provisional. So this 3-year-old came in to see Bryce with every 2-week fevers, red, warm rash, and swelling of the knees that impaired walking and swelling of the fingers. And the history came out that the mother had similar symptoms as a child and was still having monthly episodes. But she wasn't taking anything for it anymore. She had been diagnosed as systemic JIA. Well, I actually saw her as a second opinion as a teenager. And I told her, this is not systemic JIA. I don't know what you have, but it's not systemic JIA. Because we do pay attention to the fever. And this just doesn't, the fever pattern didn't fit. The lack of rash that for her didn't go along with it. The laboratory features didn't go along with it. So Bryce diagnosed 2 in one visit. So the fever can play a role, but it's not always clear cut. And And like I said, with the NOMID patient, there wasn't fever at all. This family has traps. That was a nice setup. I'm glad I had those slides. Any other questions? If not, we'll finish 5 minutes early. Thank you.
You have been disconnected from the meeting.